Ma'am, let me share my screen, ma'am. So very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's webinar is adolescent health and contraception. I welcome all the participants. I request them to post their queries, if any, in the chat box, so that we can have a short Q&A session at the end of this presentation. Today we have our invited speaker for the day. I feel privileged to welcome our Dr. C. Padmini Kumar, ma'am. Madam has done her MD DGO. Currently, Madam is the senior consultant at Pallavi Maternity and Nursing Home, Jagitial, Telangana. Madam has various posts in the past, like Foxy President 2006-7 Karimnagar branch, Vice President of IMA 2006-7 Jaglitial branch, and IMA President 2007-8 at Jaglitial branch. So, Madam has a huge experience as a consultant gynecologist, and I welcome you, ma'am, with a short introduction. I'm handing session to you for further proceedings.
Hello, can I start?
Yes, ma'am. Yes, ma'am.
Good evening, everybody. Good evening, doctors and my colleagues. At the outset, I'd like to thank Shield Connect for giving me this opportunity to speak about this topic today. Today, my topic will be adolescent health and contraception. And then I want to give just a brief description about adolescence. Adolescence is a turning point for every individual. It is a glorious journey in one's human life. It is a phase of physical, mental, social, psychological transition. It is a transition from childhood to the adulthood. They are no longer children, but yet not adults. Adolescents between the age of 10 to 19 years are often thought to be a healthy group, but many adolescents do die prematurely due to accidents, suicides, violence, pregnancy-related complications, and other illness, which is either preventable or treatable. And India has got the highest number of youngest population in the world. Almost 1/5 of the Indian population belong to are below the age of 25 years. And every fifth person is an adolescent in India. So they comprise of 22% of the total population of India, of which females comprise of 47%. So a large number of adolescents in India are out of school, they are malnourished, they get married early, and then they work in vulnerable conditions, and they are sexually active. And they are exposed to drug abuse, tobacco abuse, alcohol abuse, and sexual violence. So the main point of today's talk is making the majority our priority and focusing on adolescent health so that we'll get a healthy, productive society. They are the future citizens of our country. So mainly the adolescent plays a major role in finding out who are the vulnerable section in the society, and then educating them, and then have preventive aspects, and at the same time pick up any ill health and then treat them. So my topic on adolescence today goes in this way. The major issues we come across in adolescence are anemia and malnutrition. Second is the childhood obesity. And next comes the reproductive tract infections and the STDs, and then dysmenorrhea and endometriosis, thyroid disorders, AUB, and then pubertal menorrhagia, PCOD, acne, and hirsutism. And the other point is the precocious puberty and amenorrhea. And we also come across a lot of breast disorders during adolescence. And lastly, the psychological disorders like stress, anxiety, and depression. The word adolescent is derived from the Latin word adolescere, that is to grow into maturity. WHO named adolescence mainly the period between 10 to 19 years of age in both sexes, married and unmarried people. And then in adolescence, we have 3 to 4 stages. Adolescence is the time between the 10 to 19 years of age. Early adolescence is the period between 10 to 13 years of age, whereas middle adolescence is between 14 to 16 years, and late adolescence is between 17 to 19 years. Youth as such comprises of the people around 15 to 24 years. And then the stages of the adolescent. Early adolescence is characterized by the spurt of growth, the beginning of the sexual maturation, and young people, they start thinking abstractly. Whereas middle adolescence is between 14 to 16 years, where the major physiological changes get completed and the individual develops into a stronger sense of identity and relates more strongly to his or her peer group, and thinking becomes more reflective. Late adolescence is between 16 to 19 years, where the body takes its adult form, while the individual now has a distinct identity and has more settled ideas and options. Why adolescent health? Why we focus so much on adolescent health? The reasons being major physical, psychological, and behavioral changes take place during adolescence. There is sexual maturity and the onset of sexual activity, and development of adult mental process and adult identity occurs during this time. Healthy, responsible parenthood also occurs, and they are the great humans resource for the society. And there is growth spurt and physical activity. Menstruation starts during adolescence, and when married, even pregnancy is common in adolescence. Adolescents worldwide. When we take the worldwide statistics, around every one in 6 person in the world is an adolescent. That is 1.2 billion people are aged between 10 to 19 years of age. And most of them are healthy, but still there is a significant death, illness, and disease among the adolescents. So promoting the healthy practices during adolescence and taking steps to better protect the young people from the health risks is critical for any prevention. And global adolescent health. An estimated 1.3 million adolescents die mostly from preventable or treatable causes. So road traffic accidents are the leading cause of death, with some 330 adolescents dying every year. And globally, there are 49 births registered per 1,000 girls aged between the 15 and 19 years. And half of the mental health disorders in adulthood start by the age of 14, but most of them are undetected or untreated. Global adolescent health. Complications linked to pregnancy and childbirth are the second cause of the death for adolescents. Some 11% of all births worldwide are girls aged between 15 to 19 years, and vast majority are in the low and the middle income countries. And adolescent in India. 23% of the population in India are adolescents, and half of this group are sexually active before marriage, of which 10% of the girls are sexually active before marriage, and 20 to 25% are active before the boys are active before marriage. And fertility rate in adolescence is also high, leading to unsafe motherhood, which again leads to more of maternal mortality rate and perinatal mortality rate. And there is a low knowledge about the family planning and healthy sexuality. 98.8% in India, adolescent in India, 19.8% of the women are in the age group between 15 to 19 are pregnant. And then this fertility rate for this age population is around 107 per thousand, and 59% knows about the use of condom, whereas 49% knows about the OC pills. Contraceptive use among married adolescents is also very low, being only 7%. And adolescent in India, half of them suffer from nutritional anemia, and young people between the age of 10 to 25 years make up to 50% of the all new HIV infections. So the top killers of adolescent in India is mainly the vehicular accidents, drowning, suicide, anemia, tuberculosis, burns, and lastly the cancer. So what is what is going to occur during the adolescence. It is initially the physical growth which occurs during adolescence. First is the skeletal growth. Then secondary growth spurts occurs and 25% of the adult height is achieved during adolescence. And body composition also changes. There is a weight gain. There is an increased adipose tissue in the girls, especially over the breasts, buttocks, and the thighs. And there is an increased muscle mass in the boys. And the psychological growth. What are the psychological changes we mostly encounter during the adolescence is there is a less interest in the parental activities. There is a lot of mood swings, and there is intense relationship with the same or the opposite sex friends. There is an increased cognition. There is an increased need for the privacy, and there is a lack of impulse control, and there is an increased intellectual ability and risk-taking behavior. Sexual growth. Actually, the adrenarche occurs by the age of 6 years, where there is an increase in the serum dehydroepiandrosterone levels. And this is mainly triggered by the interleukins and the leptins. And this in turn causes gonadarchy, which stimulates the HPO axis, and then which results again in the growth of the growth spurts, and then which again leads to puberty. So puberty again has got 2 or 3 stages. The initial one is the growth spurt, and then comes the telarchy, and then comes the pubarchy, and finally the menarche. So in the girls, the breast bud forms by 8 to 12 years of age, which is termed as telarchy, and the development of the pubic hair, which occurs between 11 to 14 years of age, is called the pubarchy, and growth spurts begins by the age of 10. So menarche actually occurs between the age of 9 to 16 years, and there is enlargement of the ovaries, uterus, and the clitoris, and underarm hair by 13 to 16 years of age. Whereas in boys, this testicular enlargement occurs by 9 years, and there is a development of pubic hair by 10 to 15 years of age, and there is enlargement of the larynx and the pharynx, which gives rise to the change of voice and a hoarse voice, and then there is a weight gain and increased muscle mass by 11 to 16 years of age. And finally occurs the growth of the facial and the body hair. Adolescence and the family. Family life education. We have to educate the growing children, especially the adolescents, regarding various aspects of living in the society, interacting with others at different levels, along with imparting age. Appropriate knowledge of the biological and the sexual development should be taught. And there are 2 kinds of needs which the adolescent needs. That is, their current normative needs associated with the changing physical, sexual, cognitive, social, and emotional development. And then the next is the future family-related needs. Adolescence and family. Human relationship should be taught, and then adolescent development should be they should be taught about the adolescent development, and the values and the morals and the ethics has to be taught to the adolescents, and family as a basic unit of society, and decision making and problem solving, career goals should be taught, and planning should be taught, and finally the adolescent should be taught about the diet and the fitness. Thus, family plays a major role in teaching the adolescent and then taking care of them. And next comes the adolescence and the nutrition. For the apparent growth, nutrition is the most important factor. The major growth during adolescence is mainly the height, as nearly 1/5 or 20% of the adult height is gained during the adolescence. And then there is a weight gain. About 20 to 50% of the final adult weight gain is gained during the adolescence. And 50% of the bone mass is accumulated by the end of the second decade of the life. So nutrition plays a major role in adolescence. And then early adolescence is marked by the rapid growth phase, pubertal changes, during which time the nutrients play a major role. And it is the requirement of the nutrition is different in the early adolescence compared to the late adolescence, where the growth has already stabilized and the micronutrients have an important role. The chart which is given below gives roughly the nutritional requirement of different age groups and according to the boys and the girls. And I am not going to go through the details of this daily nutrition. And then The National Nutrition Monitoring Bureau has shown that 30 to 40% of the girls and 33 to 66% of the boys consume less than 70% of the recommended daily allowances for the protein, for the calories. So, and protein intake is also very significantly almost low. So the counseling, adolescent counseling. The adolescents are diverse in their age and then the developmental stage. Despite of all variations, adolescence is a period of exaggerated physical, emotional, social, intellectual, and the spiritual growth, with their complexities often resulting in the need for the counseling. And they require more of preventive and therapeutic counseling to address their mental health needs. Early adolescents, they are the between age group of 10 to 13 years, they are the concrete thinkers and are unable to clearly understand the cause and the effect between their behaviors and their health. Whereas middle adolescents between the age of 14 to 17, they think more abstractly. Typically, they are capable of complex logical thinking. And whereas the late adolescents between the age of 18 to 19 years, they have a longitudinal understanding of how their behaviors affect their health. And counseling focuses on risky behavior and coping skills. Adolescent mental health. Non-communicable diseases and mental health illness results in a high level of medical, social, and economic burden to the society. And most of the adult mental health disorders, they have their onset during the childhood and adolescence. In low and middle income countries, especially in India, adolescents with mental health needs often remain outside the safety of any healthcare system. An effective way to address is by enhancing the primary care pediatrician in the recognition, treatment, and referral of adolescent to the mental health specialist. Adolescent sexuality. Sexuality encompasses the whole range of thoughts, feelings, fantasies, emotions, and desires, and the language besides action. Sexual behavior is only a part of it. And sex education is important in all age groups, but it is more important than it is imparted during childhood and adolescence. And especially in India, where the sex education is considered to be a taboo, neither in the school nor in the at home, sex education is taught to the adolescent, and what is good and what is bad is not being adequately taught to the adolescent children. But especially sex education should be done on self-awareness, personal relationships, human sexual development, and reproduction and sexual behavior. And human sexuality is a function of total personality, attitude towards being a man or a woman, and the relationships among members of the same sex and the opposite sex. Help adolescents to understand their sexuality, learn to respect others' feelings, and to make a responsible decision. Sexual relationship involves respect, trust, caring of the partner, perceiving the needs of the partner, and feeling free to communicate the desires and the feelings. And adolescent health problems. What are the adolescent health problems which we come across? As already I described in the previous slide, the most important problems we encounter is undernutrition. Undernutrition leads to an impaired growth, anemia, and iodine deficiency. And iron deficiency anemia, it is almost prevalent in adolescent girls, and it ranges between 22 to 91%. And then the prevalence among girls women between 15 to 49 age is around 56%, whereas the prevalence of anemia in men is only around 24%. The reason for the iron deficiency in adolescence is there is an increased requirement for the growth of the tissues, and there is more of menstrual loss. Pubertal menorrhagia is very common during adolescence, which leads to iron depletion. And then the dislike and the food fats, which makes the adolescent not eat everything, all the iron-rich foods. That is one more major contributing factor. And then frequent dieting. Usually the adolescents skip their breakfast, which is the principal meal. And then because of their studies and then early classes, they've skipped the breakfast. And then that is also one of the major reasons for the deficiency. the adolescent problems. On one hand, we have the malnourishment. On the other hand, we have the obesity. And then the prevalence of obesity and overweight is around 11 and 14%. And prevalence is very high in boys. See, the obesity problem mainly occurs in the urban area, and because of the fast foods and then the aerated drinks. And nowadays, because of the COVID, and all the children are just restricted among the four walls and then doing the internet classes, and they are not exposed to any physical activity or the sports like where they do in the schools. And then that the obesity rate has increased more during the COVID season. And then mostly the adolescents also have eating disorders like anorexia nervosa, which is the fasting, the continuous fasting which they do, and then they do a lot of dieting, and it is a self-starved status, and then which has got a nervous origin. And then next comes the bulimia nervosa, where they overeat for a period and later they try to decrease their weight by fasting or by self-induced vomitings and then taking diuretics and taking enemas. And then binge eating is one other form of abnormal eating disorders which we commonly encounter during the adolescence. And then the reproductive problems. The teenage pregnancy comprises of total of the total pregnancy. Teenage pregnancy comprises of 16 to 90%, and then teenage pregnancy is again very common in India, and many of the adolescents become pregnant as early as 16 years. And then once the common problems we encounter during the teenage pregnancy is anemia and then malnutrition, and then they have a lot of vitamin deficiencies. And then comes the pH is very common among teenage pregnancy. Abnormal presentations are very common. Urinary genital tract infections are very common, and they go into premature labor, which is again because of the anemia. And IUGR pregnancies are very common in teenage pregnancies. And moreover, and finally, the CPDs are very common, cephalopelvic disproportion, because the pelvis is not totally formed, and then the incidence of CPD is also very high in teenage pregnancy. And then comes the abortion-related problems. Mainly in the adolescents, when they opt for an abortion, it is usually the unsafe abortion where they get it done by the local practitioners, leading again to the infections. And then further the gynecological life depends upon the future of the future gynecological life depends upon the obstetric outcome. So because of these unsafe abortions, girls are mostly prone for PIDs and then blocked tubes, and then the infection rate of the genital tract is very high when it goes to the unsafe abortions. And then the reproductive problems. The most common problems we encounter during the adolescence is the acne, which again goes to the PCOD problem, and then where you have a lot of estrogens and obesity, and most of the adolescents come with a history of acne, and then this is the common complaint we encounter during in our OP. And then comes the reproductive tract infections. UTI is very common, and then irregular menstrual cycles are also very common because of the immaturity of the HPO axis. And lastly, the vulvovaginitis and the urological issues, which we commonly encounter in the reproductive problems. And then HIV and the sexually transmitted diseases which we encounter during adolescence are HIV. The young people between the ages of adolescents between 10 to 19 years, they make 50% of all the new HIV infections. And then syphilis is also very common. Gonorrhea is also the common. And 1 out of 20 adolescents in India, they have STD problems because of the unsafe sex. A report on the World Contraception Day 2011 shows that 28% of the young people had sex and 32% of them don't use any contraception. Mental health problems. The mental health problems which you usually come across in the adolescents are the depression and the suicide, and then the psychosis, the mania, and then the conduct behavior and the anxiety disorders. Behavior problems. The behavior problems is drug experimentation. And nowadays in the paper, we daily see about the drug abuse, the youth being involved, and then there is more of exposure, and most of them become addicts, drug addicts during the adolescence. And then the other abuse which we come across is the tobacco, alcohol, and then the risk behavior in among adolescents is having a knife, rods, and rash driving. And violence is also very common. And finally, the bullying. And then the social factors in adolescent health. It is the parental perceptions and awareness about adolescents play a major role in the adolescent health. It is the parents who have to keep a close watch among the adolescents at home. And nowadays, because of the nuclear families, the adolescents are not being properly monitored. And because both parents are working, then unlike the joint families where the grandparents and all used to take care of the adolescents, nowadays because of the nuclear family, this becomes a major problem. They are not being monitored and adolescents are misled. And then the school dropouts are also very common in the adolescent group. And then in India, mainly it is the gender biased country. And then the less of female literacy was there. But now I feel there is female literacy has gone up. And economically weaker society. And then health-seeking behavior was neglected. And adolescents were not told whom to consult about the health problems. They neither visit the pediatrician nor they visit the gynecologist or the physician. So adolescents are they don't know whom to approach for their problems. And prevention of adolescent health problems. So how can adolescent health problems be prevented? So there are 3 levels of prevention, mainly the primary prevention, where policies have to be formed and information should be gathered and education should be done at the society level. And secondary prevention is the identification and then identify who is at risk and then reduce the risk of the diseases. And whereas the tertiary prevention is where you pick up the cases, treat them, and then send them to the rehabilitation centers. And Government of India also have few adolescent healthcare programs like Kishori Shakti Yojana to improve the health and the nutritional status of the women, and then the Balika Samriddhi Yojana to delay the age of marriage from 19 to 21, and then the reproductive and the child health program, and then we have adolescent friendly health services. These are called the adolescent clinics, which has to be established at the PhD level, and then everybody should be a part of it, a part of this adolescent clinics, where the ANMs and then the primary PhD doctors and then a pediatrician and obstetrician all should be attached to these clinics to give the correct information and then the awareness of the health issues. And then finally is the National AIDS Control Program, which these are all the programs which have been set up for the adolescent health. Then comes the Adolescent Nutrition and the Iron and Folic Acid Supplementation Program. And nutritional education system to generate the awareness and a balanced diet, nutritious food, and effect of malnutrition. Nutrition education sessions through Kishori Divas and then the ANMs and the school curriculum, and also linkage with the Satkar Bharat Abhignan. And child health screening and early intervention services, screening of the adolescents in the schools for low body mass index, and counseling at the adolescent health clinics. And FOXY also has a adolescent committee, which takes care of which is a very dynamic committee, and it takes care of the adolescent health. And then they focus mainly on the adolescent rights, and then they mainly focus upon the adolescent health. And they have done a various program at all levels. And then IFA tablet. IFA means it is an iron folic acid tablet. And then it mainly contains, the iron and the folic acid. It is mainly an initiative program for the management of anemia. And the adolescents between the age group of 10 to 19 years are identified within the school. And then the classes between 6 to 12 section are picked up, and where this program is done in the schools weekly, and then they give this tablet. This is called IFA tablet. The color is blue, and it has got an iron which contains 100 milligrams of iron and folic acid 500 micrograms of folic acid. This supplementation is given in the schools regularly, and then out of the school children will be reached through the ASHA workers. And then this supplementation will be continued, and this is the program which has been implemented at the village level. And then this IFA is, again we have an IFA tablet for the pregnancy and the lactation, which is a red color tablet, and this contains 60 milligrams of folic acid and 60 milligrams of iron and 5 milligrams of folic acid. And this program is called the WIFS. This is called WIFS. The total thing. The WIFS means it is weekly iron folic acid supplementation. This scheme is community-based intervention, address nutritional anemia among the adolescents. And then, as already I told you, it covers the adolescents between the age group of 6 to 11, and weekly supplementation of iron and folic acid is given, and screening of the target group for anemia and referral. And there is a biannual deworming, where 6 months deworming, once in 6 months, they do deworming with albendazole 400 milligrams. And then information and counseling for the improved dietary intake and prevention of worm infestation is the main theme of this program. And adolescent-friendly health services. As already I told you, in the sub-center, it is the health worker and the ANM who picks up the cases. And whereas at the PHC and the child, it is the medical officer, they pick up the cases. And then the primary pediatrician who picks up the cases. And then they give routine, they do a clinic once in a week, and then which is organized for 2 hours, and then they counsel, and then they teach the adolescents. And the services in the adolescent clinic. In the adolescent clinic, what services being rendered are, it is a general examination of the adolescents, and then the nutrition advice is given, and then they detect the anemia and then treat the anemia. And then they educate the women about easy and confidential access to MTP, and regular antenatal care and advice regarding the childbirth is given. And if there are any reproductive tract infections and STDs, they are being detected and treated. And also HIV detection and counseling is also done in the adolescent clinics. And lastly, it is a de-addiction, classes about de-addiction and treatment of psychosomatic problems, and counseling services are being done in the adolescent clinic. And information and counseling on the adolescent sexual health. Life skills, the abilities for adaptive and positive behavior that enables the individual to deal effectively with the demands and the challenges of everyday life. A behavioral change or a behavioral development approach designed to address the balance of 3 areas: knowledge, attitude, and the skill. This is given by the UNICEF. And then how do we educate? Life skill education. And then teaching through participatory learning methods like games and role plays, group discussion, and practicing skills through experimental learning in a non-threatening settings. And it provides the individual with a wide, alternative, and a creative way of solving the problems pertaining to drug use, sexual abuse, teenage pregnancy, early sexual experimentation, and bullying. It is a promotional program which improves the positive health and the self-esteem. So with this, the adolescent health topic is over. I am just going to the next topic of contraception. This is regarding the contraception. It is not adolescent contraception, but contraception as a whole. Can I proceed with the contraception? And half of the pregnancies in India are unintended. Only intended, the percentage of intended is only 50%, and then unintended pregnancy is only 48%, and of this 33% end in abortion. The WHO eligibility criteria for the reversible contraceptive categories are: the first category is no restriction for the usage of contraceptive method for women with that condition. And then the second criteria is advantages of using the method generously outweigh the theory of proven skills. And then third is the theoretically the proven skills of the method usually outweigh the advantages. It is not usually recommended unless more appropriate methods are not available or acceptable. And fourth is it is contraception is unacceptable health risk if it is used by women with that condition. And the methods of contraception. First is the natural family planning methods. Second comes the barrier contraceptives, and then the lactational amenorrhea method, intrauterine contraceptive devices, oral contraceptive pills, and injectable contraceptives and transdermal contraceptives, and emergency contraceptives, and then the permanent methods. The natural family planning methods. This is usually observed by many people, and then it is because there are some people, because of being religious, they don't go for the other methods. So among the natural family planning methods, first comes the rhythm method, where you follow the women's menstrual calendar, and then you choose the fertility period, which is between 10 to 20 days, and then that is the time when you avoid the intercourse. And then this is mostly observed by many of the people, but this is not 100%, where because you may have a late ovulation or an early ovulation, and then the sperm also survives for 2 to 3 days in the cervix. So next comes the basal body temperature. Basal body temperature is where you monitor your temperature daily once getting from the bed. You just monitor your temperature daily, and then progesterones being thermogenic, once there is an ovulation, there is an increase in the temperature by 1 degree. So that is the time when you know that ovulation is taking place, and that time you, according to your menstrual rhythm, you avoid the intercourse. And this is also one method of the natural family planning. And then comes the cervical mucus method, where you see the cervical mucus, we observe the cervical mucus, and then as the estrogen levels in the body increases, the cervical mucus becomes thinner and it becomes copious. So this is the time you know that the ovulation is occurring, and so women try to avoid intercourse during this time. And finally, it is the withdrawal method, where this is a coitus interruptus, which some men practice to avoid pregnancy. Then comes the barrier contraceptives, and we have many barrier contraceptives, like it is the condoms, which is used by the men, and then the vaginal diaphragm and the cervical cap, which is used by the females, and there is a vaginal sponge, which is inserted into the vagina, which is coated with spermicidal agents, and then the female condom, which is inserted high into the vagina, and lastly the spermicide agents. But these barrier contraceptives are not a guarantee, and it has got a lot of failure rates. And then comes the intrauterine contraceptive device. The IUCD is one of the best methods of contraception, especially during lactation, because of its high efficacy and because of its lack of effect on the breast milk and the infant growth. It doesn't interfere with the lactation. And then you have 3 generations of IUCDs. The first is the inert device, Lippis loop, which used to be inserted in 80s and 90s. And this is just an inert one. It is a coiled inert device, which is inserted immediately after the delivery. And then the second generation IUCD is all the copper containing devices, which we mostly use. And this copper is a spermicidal, and it inhibits the ovum also to grow. So, and thirdly it is the hormonal devices, which is the Progestasert and the Merina, which is used. And these copper teas, they are made up of polyethylene, and it has got a copper wire, and the copper tea 380A, it also has got a silver core, and the lifespan of copper tea 380A is 10 years, whereas other copper teas, they have a lifespan between 3 to 5 years. And then only the Progesterone Iud, this is called Progestasert. It is a progesterone IUD, and where 38 milligrams of progesterone is dispensed in a silicone oil, it delivers progesterone to the uterus at the rate of 0.65 micrograms per day and effective for 1 year. And then the Merina or the LNG IUD or the Levanova. This Merina contains 52 milligrams. This contains 52 milligrams of levonorgestrel, and it is LNG is released into the uterine cavity at the rate of 20 micrograms per day. It acts up to 5 years, and this Merina is very useful where a woman wants to have a contraception, and it is preferred at the age of 40 years, and it is also helpful for those who have heavy menstrual period, and then and it can be inserted for people with small fibroids too. And the incidence of ectopic is also very low with the Merina. And we also have some post-placental IUCD insertions where IUCD is inserted immediately after the delivery or after the cesarean. And then we have interval insertion, and one is immediately after the vaginal delivery or the cesarean, and one is after the interval insertions, and then the which is inserted after 3 months after the delivery. And the newer IUCDs are the FlexiGuard or the Gyniflex, which is a frameless IUD, 3 centimeters long, and it has got 6 copper sleeves, 300 sequence millimeter of copper strung on a surgical polypropylene nylon thread knotted at the upper end. These are the new IUDs. Copper T is a safe IUD, and then it's a T-shaped radio-opaque plastic body, and the ends of the flexible transverse arms are inwardly bent, providing a non-irritating fundus-seeking mechanism. And the complications of IUD. Complications of IUDs are increased bleeding, misplaced IUD, and infections, and sometimes pregnancy occurs with in situ copper T, and the ectopic pregnancy rates are also high with copper T, IUDs. Then comes the oral contraceptive pills. Contraceptive pills, this is the most commonest method of contraception accepted by many, and it has got the combined pills are 2 types. One is a monophasic pill and second is a multiphasic pill. Monophasic pills, these pills have got estrogen, progesterone in the same amount in each pill. Whereas a multiphasic pill, it has got an amount of estrogen, progesterone in 2, either biphasic or 3 triphasic periods within the menstrual cycle. And in a multiphasic pill, the dose of progesterone is low at the beginning and higher at the end of the cycle. And then mostly the contraceptive pills acts by the estrogen component of the contraceptive pill acts upon the FSH. It causes a negative feedback mechanism, and so the FSH trigger is lowered. And then the progesterone in the OC pills, that causes that inhibits the LH surge and the ovulation. And also progesterone has got it causes a thick cervical mucus, which prevents the sperms from ascending up. And then it also causes, it also inhibits the endometrial growth. The estrogen commonly encountered, which we with the oral pills usually have, is the ethinyl estradiol, which is the main estrogen present in all OC pills. And then the content of the estrogens, starting it was around 50 micrograms, and that the estrogen content in the OC pills, which causes more of DVTs. So gradually the strength of the ethinyl estradiol is being brought down to 30 and 20 micrograms. And then nowadays we have progesterones, which are the 3rd generation, 4th generation, and the 2nd generation progesterones, which are being used in the oral contraceptive pills. And these lower dose of estrogens and the progesterones and the higher new generation progesterone are mainly, they decrease the side effects of the OC pills, and then the acceptance is also more. The main problem with the OC pills are breast tenderness, and then the DVTs and arterial thrombosis. So because of this, usually it has to be used with caution with the previous history of migraine, obesity, and any heart problems and high lipid profile women. And this OC pills is mainly used during the fertility period, when women between 20 to 30 years, 35 years, mostly they go for the OC pills. Then comes the injectable contraceptives. The injectable contraceptives is the progesterone only injectable contraceptive is dipomedroxyprogesterone acetate. This dipomedroxyprogesterone acetate is the progesterone injection, which is very useful for the lactating mothers, and this is the best choice for the lactating mothers as it doesn't interfere with the lactation. And it is mainly given during the first dose should be given within the 5 days of the menstrual period, and then the effect lasts for 3 months, and then it has to be repeated once in 3 months. The only side effects of the Deppoprovira is there is a breakthrough bleeding, there is a continuous spotting, or some people experience on and off bleeding, and some people go in for amenorrhea, because this Deppoprovira acts upon, it causes hypoestrogenism and makes the endometrium very thin. And then this Deppoprovira is usually mainly, it is a preferred contraception for those who have heavy menstrual bleedings, and then it is mostly for the lactating women. But the return of fertility is slow in case of Deppoprovira. So return of fertility is usually only after 6 months to 1 year, and more than 3 doses are not recommended. And the side effects of Deppoprovira are mainly the obesity, and then the bone mineral density is lowered, and then the return to fertility is takes a long time. These are only the 3 advantages for the Deppoprovira, and mostly it is not preferred during the perimenopausal age group and about 40, above the age of 40. And then comes the transdermal contraceptive patch, which has got estrogen and progesterones, and then you wear these patches. This patch works only for 1 week, and then you put it on any part of the body, like arms, thighs, abdomen, but not on the breast. And it works for 1 week, and then every 1 week you have to replace the patch. And then you use 3 patches, and it contains both estrogen and progesterone, and both are released transdermally, and then followed by 1 week patch free. The last 1 week, there is no need to use a patch. It is only a weekly 1 patch for 3 weeks. It is mainly used by the young adolescents and those between 20 to 30 years. And then comes the emergency contraception. Emergency contraception is when you have the other methods failure, or when there is no contraception. As an emergency, you don't have any contraception with you, and then you had an intercourse, and then you want to prevent the pregnancy, then you go for the emergency contraception. And it is mainly the levonorgestrel pill. It is 0.75 milligrams taken as soon as possible after the unprotected intercourse, and the same tablet, 1 more tablet, to be taken early in the morning, 12 hours later. But both doses should be taken within 72 hours of the intercourse. This also works well as an emergency contraception, but I think it cannot be used for more than 2 or 3 times per cycle. Mifepristone. Latest WHO randomized trial has noted that a single dose of 10 milligrams of mifepristone is as effective as LNG for emergency contraception. And then no side effects, and the period starts after 7 days, because mifepristone is antiprogesterone. It prevents it acts upon the cervical mucus, and then it acts upon the endometrium and doesn't allow to practice. But this has not been registered as a emergency contraceptive pill in any country. Just only for the theoretical purpose, we can document this. And then comes the other thing is, besides the mifepristone, and then we're in abroad countries where they go for a implant, that is naproxenol, which is a subdermal implant, which is inserted into the inserted in the arm. And then this is a subdermal implant which releases the estrogen and the progesterones, and then it mainly inhibits the ovulation, and then has action upon the endometrium and as well as the cervical mucus. And it is mainly the contraception practiced during adolescence in the abroad countries, where it is inserted subdermally in the arm, and then 8 to 10 centimeters above the medial epicondyle of the humerus. And then you give a local anesthesia, and then you insert the implant. This is a radio opaque rod about 3 centimeters, which is implanted below the skin. And then there is a special device for the implantation, which implants, and then you put a suture over that. And then the effect of the contraception lasts for 3 years. And this is the most accepted in the Western countries. And then once you want to remove that, and usually you can just palpate and then give a small incision and then you can remove. And then the main problem with the subdermal implants are it lasts for 3 years, and then suppose if care is not taken, and it is mainly inserted in the first within the 5 to 7 days of the period of the LMP, and suppose if the pregnancy occurs, and then it cannot be continued. So once pregnancy has occurred before the implant has been inserted, then remove the implant immediately. Or if the patient wants to go for an MTP, if she is pregnant, do MTP and continue the implant. And then finally, the permanent methods. Permanent methods are the male sterilization, that is a vasectomy, which is mostly done in the camps in India. And we have so many camps in India being done. And then vasectomy are being done by the family planning department, and they encourage this. But in India, the rate of vasectomy is how much ever you educate the men undergoing vasectomy is comparatively less when compared to tubectomy. And in the vasectomy, you give a small incision over the scrotal sac, stabilize the vas, pick up the vas, and then cut the vas. So, and again, we have the non-scalpel method where a shot is given, stab incision is given, and the vas is picked up. And this is no scalpel method, and which is very easy to be done, but it requires trained doctors, and then there is no pain, the failure rates are very less, and then the complications are very less. Then comes the female sterilization. Female sterilization, it can be done in many ways, and then it can be done per abdomen, where you can go for an open method, or you can be done by laparoscopy, where you do laparoscopic sterilization by putting the loops. And then the traditional method of tubal ligation is where you pick up the tubes, and then and you select a point between the lateral 1/3 and the medial 2/3. This is the point where the tube is ligated. And you have different methods in tubal ligation, where sometimes you pick up the tubes, cut, and you cauterize the ends. But cautery causes sinus, and there is every chance of sinus formation. So this is not the preferred method. You better avoid cauterization during the tubal ligation. And then comes, you pick up the tubes, tie the ends, and then cut the ends. And then the third method is the banded method, where you pick up the tube and then you form a loop. And then once the loop is transfixed, and then put two sutures. One is a transfixion suture, transfix suture, another one is the one suture above that, and then you cut the tube. Every method of family planning has got some failure rates. So nothing is 100%. And so that's why you have to educate the patient about the failure rates and the complications, and then what are the side effects of the thing. And the couple has to be counseled. And then the permanent method, and you should also counsel the couple that permanent methods are irreversible. And finally, in abroad, they do hysteroscopic coil insertion, where they insert through hysteroscope. This just takes a 10 to 15 minutes procedure, and then where you put a hysteroscope, and then there will be coil. There is a silicone, titanium, and titanium coil, and then that is like a spring where you occlude the ostia of both the tubes, and then you just occlude and then you come away. Then this by the fibrosis, it occludes the ostia, and then both the ostia and the tubes inlet is blocked. So this also is a good method of family planning, but mostly done in the Western countries. So I finished my talk here. Thank you all for the patient hearing.
Thank you, ma'am. Thank you very much for that detailed presentation, ma'am. Rather, I could say it as a awareness webinar for everyone, ma'am. Yes, ma'am, from your presentation, I can take 3 points, ma'am. Like one is the current generation, particularly at the adolescent age group, they are so advanced, ma'am. So the human relationship, the nuclear family is there, and the human relationship has been reduced. And the second thing is healthy food and nutrition is not taken by the adolescent age group.
Yeah.
Yeah. And the third point is the behavioral problems, ma'am. Like there is no one to monitor, as you said. In the olden days, there will be more people to monitor any child or any adolescent girl or boy, but nowadays it is missing, ma'am. And ma'am, coming to the contraception, ma'am, I have some few queries, ma'am. Like there are when it comes to oral contraception, there are progesterones alone or progesterones mixed with estrogens. Yeah, ma'am. So which one will be best to take in adolescent age group, ma'am? Because when it comes to women, when they attain their puberty or PCOS, is one of the major problem, ma'am. In those criteria also, they are taking these oral contraceptives, ma'am. So who should avoid a contraceptive, and which one is best for the adolescent girls, ma'am?
For adolescents, it is mainly the low dosage pills. Like we have, can I mention the trade names?
No problem, ma'am. You can say, ma'am.
Where you have a low dosage of estrogens, like Oral and then Yamini. These are all the preferred for the oral as oral contraceptives for the adolescent age groups, which has got a low content of the estrogens, because it is mainly the estrogens which is the blaming agent in the contraceptive, and then prolonged usage also gives rise to problems. So adolescent, actually the preferred method adolescent they go for is the mainly the emergency contraception, and then the condoms and the barrier methods. That is mostly accepted by the adolescents. Rather than few people will take OC pills, but these are the things they take most. Among the OC pills, it is mainly the Dronis, this is which contains ethinyl estradiol and drospirenone. That is preferred. And when a PCOD adolescent, when they have PCOD in addition, we prefer to use ethinyl estradiol plus cyproterone acetate. Combination is the best for PCOD people, because that takes care of the acne and then the hirsutism also. And then for the regular OC pills, it is the ethinyl estradiol with the drospirenone that is preferred for adolescents, or the low dose estrogen pills. Only progesterone pills is only advisable for the lactating mothers, where you have only the progesterone, like Cerazid.
Okay, ma'am. Ma'am, one more question, ma'am. Like the copper tea. So when they are having this copper tea, so what are the disadvantages or what are the adverse effects, ma'am? Since it is using for a long time, so what are the common adverse events?
See, once copper tea is inserted, the first checkup should be within 2 months to check whether it is in position or not. And after that, every 6 months they should come to the gynecologist and have a regular checkup about the position of the copper tea, and then whether they have any associated white discharges and the PIDs. But here in India, mostly they get the copper tea inserted and then they disappear. They never come for checkup. Only at the time of removal they come. But you should instruct the women to have a regular checkups, because copper tea, because of the threats, there is an increased infection for the PIDs and all. So and then even the menorrhagia is also very common with the regular copper teas. But with the newer system of copper teas, the menorrhagia has come down, and then cramps, dysmenorrhea is common. And one more thing for the copper teas is first 3 days they don't have bleeding, and then they just have spotting, and from third day it is a heavy bleed for the next 5 to 7 days. So the disadvantage of copper tea is first you should check the position. Sometimes it may be lost. So they should have a regular checkups for the leukorrhea, and then to screen for any infections. And then comes when they have menorrhagia, they should be treated. So all these things, before putting the copper tea, you should advise the patient about all the side effects, educate them, and you should ask them to come for regular checkups rather than getting inserted and disappearing.
Okay, ma'am. Ma'am, coming to this emergency contraceptive pills, ma'am. So we can even nowadays we can see many TV advertisements also on these emergency contraceptive pills, ma'am.
Yes.
So is that a right way to approach, ma'am, or whether they can take it for 2 or 3 times?
Yeah, that's what I told you in my talk also. Because emergency contraception is only an emergency. It is an emergency use when all the other methods have failed, or you don't have any contraceptive with your hand on hand, and you have a intercourse, and then you don't want to have a pregnancy. This the name itself indicates it is only emergency and not for regular use. And I don't think it has to be used more than 2 or 3 times a month.
Okay, ma'am.
1 or 2 times is, but not more than 3 times a month.
Okay, ma'am. Ma'am, I don't have any questions in the chat box, ma'am. So if you allow us, then we can end the webinar for today, ma'am.
Okay.
Yeah, ma'am.
Thank you.
Thank you, ma'am. Thank you very much for your active participation and for spending your valuable time with us today, ma'am. And I will also
It's a privilege, I feel.
Yeah, ma'am.
Because I became a student after a long time. I had to refer so many books and I collected so many points. And then see, once you have to teach, you have to become a student. First, you have to learn and then teach. So actually, have helped me in going through the books and then collecting some information.
Yes, ma'am. It
Thank you.
was absolutely an informative session, ma'am. I'd like to thank the participants for their active participation, and I'd like to thank my our team for making this webinar possible, ma'am. They have arranged a very good, wonderful speaker for the today evening, ma'am. Hope the participants found this session very informative, and it is like not only for the doctors, ma'am. It is for like a general public also, ma'am. So it was like a awareness program, ma'am. Thank you very much, ma'am.
Yeah, thank you once again for giving me this opportunity.
Nice. Ma'am, we are looking for many more interesting webinars with you, ma'am.
Yeah, definitely.
Sure, ma'am.
Because as I told you, I learn first and then again I tell you something.
Thank you, ma'am. It's
Definitely,
always a
if I
pleasure,
find
ma'am.
time,
Yes,
definitely
ma'am.
I'll do it.
Thank you, ma'am.
Yeah.
We're ending the webinar for today, ma'am.
Yeah, thank you so much.
Thank you very much.
And thank you, audience, for the patient listening too.
Yeah, ma'am. Ma'am, can you give this presentation as a blog for our website, ma'am? It will be more useful, ma'am.
Okay.
Yes, sure, ma'am.
Okay.
Thank you.
Okay. No problem.
Thank you very much.
Yeah.